Hello, everybody. So hope you all have been enjoying the beautiful start of the fall season, and I cannot believe it's almost the end of the year. This year has just, flown by. I apologize sincerely for the brief hibernating period that you all have experienced on my Instagram and Facebook page. I haven't really actively talked about new cases, and I definitely have been missing the interaction and all the teaching. Thank you for your wonderful support and for all the feedback that I have received. Based on popular demand, I have decided to approach back the inflammatory dermatopathology in a more systematic way. So starting today, we'll be talking about inflammatory dermatoses. I know that that's one of the more challenging aspects of dermatopathology. So I definitely want to talk about that and teach you guys, whatever my experience has been and, whatever we encounter in a day-to-day setting. So, the kind of approach that I was thinking about, which would be most practical and useful for, a lot of residents as well as actively practicing clinicians out in medicine would be to teach you guys in a systematic way about each inflammatory entity and then, delve into the details and the subtle distinguishing features of of varying entities in a more clinical basis. So, how we encounter this in a clinical setting, how, which tips you would use to distinguish between simple entities like eczema psoriasis or pityriasis rosea, guttate psoriasis, to name a few. And, basically, essentially, build a building block and we can progress on from there. So we all know that inflammatory dermatopathology is all about recognition of reaction patterns. The diagnosis is typically made on low power, which is, 4x is what, where I like to stay and make the diagnosis. And then you fine tune your diagnosis by going on high power, and absolutely essential is the clinical presentation, the clinical path correlation. You can never make a diagnosis of an inflammatory dermatosis in isolation. There are certain features for every entity which are classic and diagnostic, but overall clinical pathologic correlation is the backbone of dermatopathology. So, that's what my approach is going to be. We're going to talk about inflammatory topics, but in a more practical and clinical setting. Again, coming back to the dermatopathology reaction patterns, they are what I essentially call are the pillars of dermatopathology. So when you look at a biopsy on low power, you are automatically classifying the disease entity into one category versus the other. There are pretty much 8 or 9 common reaction patterns, which right away when you look at a biopsy, you can classify in those entities. And then you fine-tune your diagnoses. So we are going to start today with the most common reaction pattern, which is spongiosis. We're going to talk about that. And I'm going to teach you what I know about Spongiotic reaction pattern. And then starting tomorrow, continuing in the week, we will talk about, cases related to Spongiotic dermatoses, which come in a more practical setting, and how we use certain features to distinguish between the various entities. So starting with the most common reaction pattern, which is spongiosis. So the spongiotic reaction pattern, which essentially means fluid in the skin, so fluid in the epidermis and dermis, is manifested under the microscope in the form of varying degree of epidermal acanthosis. So you can see thickening of the epidermis, which is acanthosis, along with the intercellular edema inside the epidermis is manifested as prominence of desmosomes. So we all know that the desmosomes, which are your intercellular junctions, are normally not visible, but when there is intercellular edema, when there is fluid in between the cells, you see prominence of these intercellular junctions or desmosomes because of the fluid, which also causes a pale-looking appearance of the epidermis, and that's one of the very common features of spongiosis. Now, this prominence of the desmosomes or fluid in the epidermis is accompanied by inflammatory cell exocytosis. So obviously, whenever the body is exposed to something abnormal, which in this case is fluid in the epidermis, which it normally shouldn't be there, it's going to react in the form of an inflammatory cell reaction. So inflammatory cells are going to pour out into the epidermis, referred to as exocytosis. You can have lymphocytes, eosinophils, or neutrophils pouring out. Most commonly, you see lymphocytes. You can see eosinophils in allergic contact dermatitis. And then you have on the top the parakeratosis with the serum and the crust formation, the parakeratotic crust. And this crust is also what is going to be visible to you clinically on the patient's examination, the serum and the crust. So again, the triad of a spongiotic process is intercellular edema manifested as prominence of desmosomes, inflammatory cell exocytosis with these cells pouring out, and the parakeratotic crust formation. Now, the spongiotic reaction pattern is, as I said, is a pretty common reaction pattern encountered in dermatopathology. Now, spongiosis, when I use the word spongiosis, most often a spongiotic dermatitis is synonymous with an eczematous dermatitis. So whenever I call it a primary spongiotic process, I'm referring to a primary eczematous dermatosis. But again, remember that spongiosis or fluid in the epidermis can also be seen in a whole lot of different diseases like psoriasis, erythema multiforme, or pityriasis lichenoides, as we will discuss later. But when we are talking about a primary spongiotic dermatitis, we are referring to a primary eczematous dermatosis. Now, after you decide that yes, this is a spongiotic pattern, you are going to further delve into the degree of spongiosis. So you classify the spongiotic reaction pattern as acute, subacute, or chronic based upon the amount of fluid in the epidermis. And also it often correlates with the chronicity or the acuteness of the lesion. So acute spongiotic dermatitis, we see a lot of intraepidermal fluid. So you can see that there is a lot of fluid in the epidermis, and this is manifested as formation of these intraepidermal spongiotic vesicles which contain this pink inflammatory serum and coagulum. And this will also be visible clinically in the form of fluid-filled blisters. So often you will see this clinically, for example, in poison ivy, contact dermatitis, classic example of an acute acute eczematous process wherein you see these fluid-filled blisters inside the epidermis. There is often varying degree of dermal edema as it is encountered over here, but the pathognomic feature of an acute spongiotic process is presence of these intraepidermal vesicles containing fluids with often marked papillodermal edema, which can also result in a secondary subepidermal vesiculation. A subacute spongiotic process has lesser amount of fluid in the epidermis, so you're not really going to see the blisters, but you can still recognize that this is a spongiotic process. You see variable degree of erosion and crust, dermal edema, and again the inflammatory cell exocytosis with the prominence of the desmosomes, as you can see over here. But again, you do not see the prominent fluid-filled blisters, but it again looks very wet. You know this is a spongiotic process because of all the fluid. And then finally, we have a chronic spongiotic process where there is minimal to absent fluid in the epidermis. It's a chronic process, so the fluid in the epidermis has kind of like subsided, and what we are basically left behind is with just the telltale signs of a chronic eczematous process, which is manifested in the form of variable degree of epidermal thickness. So you see acanthosis, hyperkeratosis, but there is minimal fluid. But again, you can notice that there is in some areas prominence of desmosomes. So you can see the mild intercellular edema with the inflammatory cell exocytosis. So this is a chronic spongiotic process, minimal fluid, but you do see the telltale signs of an eczematous dermatosis manifested in the form of epidermal acanthosis, hyperkeratosis, and varying degree of parakeratosis. Now, so now you have classified the spongiotic dermatitis as acute, subacute, or chronic, and in the appropriate clinical context that is consistent with the primary eczematous dermatosis. Now, eczematous dermatosis, we all know, could be clinically nummular, atopic, allergic contact, asteatotic, stasis, dyshydrotic dermatitis, or an id reaction. So pretty much all these 7 entities classically come under the category of a primary eczematous dermatosis. And again, I'll repeat them. It's nummular, allergic contact, atopic, asteatotic, stasis, dermatitis, dyshydrosis, and id reaction, or an autoeczematization. Now, just by looking at the slide, you really cannot classify what kind of an eczematous dermatosis it is. So that's more of a clinicopath correlation. However, there are certain clues that will be helpful in deciding what kind of an eczematous process it is. So for example, in an allergic contact dermatitis, you will see the presence of intraepidermal spongiotic vesicles. Again, the epidermis looks very often wet. You can obviously have a chronic spongiotic process as well in contact dermatitis. But you generally see a wet-looking epidermis, variable degree of epidermal hyperplasia. The presence of eosinophils in the superficial dermis, if it's a prominent cell, often points towards contact dermatitis. You may see eosinophils pouring out in the epidermis. As you can see over here, there are subtle foci of eosinophilic exocytosis. So you would think about, more contact than nummular. Typically, prominence of eosinophils in the dermis favors contact than other entities. Another very reliable feature, which I often use, is the presence of these intraepidermal Spongiotic vesicles, which are containing a collection of Langerhans cells. So microvesicles containing collection of Langerhans cells. For example, in this particular entity, you can see that there is epidermal acanthosis, presence of intraepidermal Spongiotic microvesicles, and you can say that they contain these small Langerhans cell collections along with other inflammatory cells. So you can see these kind of irregular nuclear contours of these cells with the with the cytoplasmic pink cytoplasm surrounding them. So these are clearly histiocytes. Some of them even have these kidney bean shaped morphology, along with the presence of lymphocytes. So whenever you see collection of antigen presenting cells or Langerhans cells in the epidermis forming these microvesicles along with a dermal infiltrate which contain eosinophils, that's very consistent with contact dermatitis. So nummular dermatitis typically tends to be non-discrete. You just see variable degree of spongiosis, acanthosis with a superficial perivascular lymphocytic infiltrate it may have a few eos, but generally eosinophils are not that prominent and do not see these Langerhans containing microvesicles in the epidermis. But again, disclaimer, really the distinction between various types of eczematous dermatoses is more clinical rather than it is under the microscope. Now, I think for today I'm going to leave it over here. Tomorrow I'm going to again continue the discussion more about different types of eczematous dermatoses. I'm going to talk about stasis dermatitis, dyshidrosis, arthropod bite reaction, and so pretty much I think for the next few days I'm going to be talking about eczematous dermatoses, and then we will start quizzing you with some more practical clinical questions and how to approach these biopsies in a more practical manner. So thanks and have a great day.